This is part 3 for the chapter in the heart. In this class, we're going to focus on the cardiac cycle. And this will put everything into perspective as to what it is that we're doing here when we're talking about action potentials and when we're talking about contraction of the different heart chambers. Let's start with the cardiac cycle. So the cardiac cycle is the period between one heartbeat and the start of the next. Now, during this cardiac cycle, each one of the chambers of the heart will go through two phases, and that is contraction and relaxation. Now, whenever we're going to talk about contraction and relaxation, we're going to use the term systole and diastole. Remember that we have four cardiac chambers. The top of the chambers are the atria, and the bottom chambers, the pumping chambers, are the ventricles. So each one of these chambers will go through systole, contraction, and diastole. And the ventricles, each one of them, right and left, will go through a systole and it will go through diastole. As we mentioned before, each one of these cardiac chambers will go through different processes, and that is systole and diastole. Systole means contraction and diastole means relaxation in relation to whichever chamber you're talking about. We're going to start our cardiac cycle with atrial systole, which means atrial contraction. So during this atrial contraction, we're squeezing the last bit of blood from the atria to the ventricles. Remember that the ventricles have already been filled passively by about 70% prior to the atria contracting, and that is just because of the AV valves being open. Once we finish atrial systole, we will start atrial diastole, which means we start relaxing the chambers, and the atria are mostly relaxed for the rest of the cardiac cycle until the beginning of the next. We then proceed with ventricular systole. Ventricular systole can be divided into two phases, an early phase and a late phase. The early phase is known for something that is called the isovolumetric contraction. And we'll talk about what that is in a second. But this late phase is known for the opening of the semilunar valves once we start that ventricular systole and we start ejecting blood through those arteries. So what is isovolumetric contraction? Isovolumetric means there is not a change in volume and there is contraction without a change in volume. So as we start early into the contraction of these ventricles, there won't be volume changes. That means that there is no volume leaving the chamber or volume entering the chamber. And when we talk about volume, we're talking about blood. The amount of blood that is in the ventricles will remain the same, will not change. This allows for the atrioventricular valves to close. And once we have reached enough pressure within that ventricle, we overcome the pressure of the arteries and we eject blood, and this will be related to that second phase. And again, once we finish atrial systole, atrial diastole starts, and the atria remain relaxed for the rest of the cycle. But in regards to the ventricles, as soon as we finish atrial systole, we also start ventricular systole. And that is divided into two phases, the early phase and the late phase. The early phase is related to a contraction of those ventricles without blood leaving the heart just yet. And with that, we're going to close first the atrioventricular valves close. On the right side of the heart, we're going to close the tricuspid valve, and on the left side of the heart, we're going to close the mitral valve close. And this is what is going to give rise to our first heart sound. When we first close that atrioventricular valve, you're going to hear the first heart sound. And as soon as and that is from the early phase. So isovolumetric contraction with first heart sound related to the atrioventricular valves closing. And then the second phase, once there is enough pressure, we are trying to overcome the pressure that is within the arteries. All right. Remember that there is blood in here within the pulmonary circuit and systemic circulation. But we want to build enough pressure to overcome that. And once we do that, we open up the semilunar valves, either be the pulmonary or the aortic valve, and we push through. And this happens during that late phase, semilunar valve opening. Now the blood is now ejected through. Once we end the ventricular systole, we will start ventricular diastole. So as we move on to that ventricular systole, the first phase is related to that isovolumetric contraction without a change in volume. And into that late phase, we are now having enough pressure to overcome the pressure of the arteries. And we have now ejection of blood through those arteries to either be the pulmonic or the aortic circuit, the systemic circuit. Now we finish our ventricular systole and we will start our ventricular diastole, which means the relaxation of those ventricles. This ventricular diastole, we are also going to divide it into two phases, the early phase and the late phase. The early phase can be known for something that is called the isovolumetric relaxation, which means that the pressure gradient within those ventricles will fall, but it's not enough so that those atrioventricular valves will open. Remember that the atrioventricular valves are connective tissue, so they are not muscles that contract and open based on a stimuli, but they just open up based on pressure changes. If the pressure from the atria is greater than in the ventricles, then the atrioventricular valves will open to allow the passage of blood. Right now, because we were just finishing the ventricular systole, the pressure within the ventricles is still higher, keeping that pressure in the ventricle higher than the atria, and that is why they are closed. Now, during the early phase of that ventricular diastole, the pressure during the first phase, as we start increasing the space within that ventricle, we increase volume without a change on actual blood, the pressure will fall. And once the pressure falls, the valves open, and then it is when the blood starts rushing into that ventricle. So, in summary, ventricular diastole is divided into two phases, early phase and the late phase. The early phase is known because there is isovolumetric relaxation, and this allows for the lowering of pressure of those ventricles. So in the second phase, the late phase of ventricular diastole, all the chambers are relaxed. Your atria and your ventricles are all relaxed during this phase. So late phase should be known for all chambers are relaxed. It should also be known because of the fact that now the pressure within the ventricles is falling low enough so that the atrioventricular valves open. And now there is passive filling of blood of that ventricle. Of ventricles. So it is during this phase, somewhere around here, the atrioventricular valves will allow that blood to flow from the atria into the ventricles, and we will fill about 70% of that ventricle through that passive process. And it is at the beginning of atrial systole that we will squeeze the remaining portion of that blood that is still in the atria to continue to fill that ventricle. And we will end that ventricular diastole at the end of atrial systole. Remember that this will be with the opening of those, the closure of those atrioventricular valves. Closure of AV valves. let's recap. So the cardiac cycle is related to the period of time in which one heartbeat starts and one heartbeat ends. And during this cycle, we have the different cardiac chambers undergoing either atrial systole or atrial diastole. They all undergo a series of changes, and within this contraction and relaxation, systole or diastole, there is a change in pressure. Remember that when we are undergoing systole, we have a rise in pressure. When the atria are contracting, that contraction causes the pressure to increase and then moves blood from one chamber to the other. The same goes for the ventricles. When the ventricles start to contract, the pressure rises and it pushes the blood outside the semilunar valves and it shuts those atrioventricular valve closed. All right. The pressure now will decrease once we go into relaxation. So the atria, as soon as they start diastole, it will increase their size, and because there is increasing in size, there is a fall in pressure within the atria. All right. Now for the ventricle, if it starts to expand, there will be more space, so then it will allow for a decrease in pressure, allowing blood to come in. This is important because it is this change in pressure that allows the opening and closing of valves. Remember that blood flows from high pressure to low pressure. The controlled, this allows also the timing of when it is that we're moving blood from one chamber to the next. Okay, let's review the cardiac cycle. During atrial systole, we have contraction of the atria to fill the remainder of space into that ventricle that has already been passively filled by about 70% through just a ventricular diastole. Atrial diastole is led throughout the rest of the cycle and it starts once atrial systole ends. And it is a long phase. Ventricular systole starts right at the end of atrial systole. And with this, we have the first phase and the second phase. The first phase is known for its isovolumetric contraction. And what we're doing here is we're starting to squeeze those ventricles and we're increasing the pressure without augmenting the amount of blood that is within. So those ventricles start to contract and the pressure starts to rise little by little. And once it reaches enough pressure, it will go ahead and eject blood through those arteries. Keep in mind that during this first phase, we also close the AV valves. And it is in the second phase that we overcome systemic and pulmonic pressure and we go into the arteries. And semilunar valves open. Now, ventricular diastole starts at the end of ventricular systole, and this is the relaxation of the ventricles. As soon as the early phase starts, we have isovolumetric relaxation. And this means that the ventricles start to increase in size, lowering the pressure, allowing for those atrioventricular valves to open, and it is in this late phase that the AV valves actually open. And there is passive filling of those ventricles. And we fill them up to about 70%. Okay? Keep in mind which valves are open and which ones are closed within each cycle. If we're going through atrial systole, the AV valves will be open. If we're going to atrial diastole, as soon as we start the ventricular systole, there will be a closure of the AV valves, and then later on, the semilunar valves will be open in the second phase. Ventricular diastole, we don't open those AV valves until the late phase of the ventricular diastole. And remember that before atrial systole, the first phase of the cardiac cycle, all right, the atrial systole is the first phase, the atria and the ventricles are all relaxed, and the AV valves are open, and there is passive filling of the blood. Semilunar valves are closed because the pressure within systemic and pulmonic circuits are higher than in those ventricles. Again, during atrial systole, the atria contract. When they contract, the AV valves are open. The ventricles had already been filled passively 70%, and it is during that contraction that the last bit of blood will go into the ventricles. The ventricles blood volume at the end of atrial systole is known as end diastolic volume. So before we get into ventricular systole, remember that your cardiac cycle starts with the atrial systole, and as soon as atrial systole, we're going to put AS, it starts, then we go into atrial dilation. Now, your ventricular dilation has undergone, and it also ends, we'll put in ventricular dilation, it also ends with the end of atrial systole. Now, the volume that is within your ventricles at the end of the systole is called end diastolic volume. All right. Now, it is once we finish that ventricular diastole, then we start our ventricular systole, and it's divided into two phases, early phase and late phase. Let's go over the early phase. During the early phase, the AV valves are closed because we haven't reached enough pressure within that ventricle. We're undergoing isovolumetric contraction to increase that pressure within that ventricle. So we have our heart, and those ventricles are now starting to squeeze, starting to contract. They are undergoing systole. And as we are undergoing systole, the pressure inside this chamber will increase, but it's not high enough yet. And that is why the AV valves the semilunar valves are closed, because there is not enough pressure to overcome that systemic and pulmonic pressure. Now the AV valves will close at the beginning of this phase, and it is the closure of these valves, as soon as we start that isovolumetric contraction, that will lead to the first heart sound. That lobbed up, it will be the lob, okay? And as soon as we have enough pressure built up from that isovolumetric contraction, then we'll start the late phase. And within the late phase, we have enough pressure to go into systemic and pulmonic circulation. So pulmonic from the right ventricle and systemic from the left ventricle. The semilunar valves are open now. Now the amount of blood that is ejected from each ventricle is called the stroke volume. So at the end of ventricular systole, the ventricular valves will close, and the remainder of volume that is in that ventricular diastole start will go right into that ventricular diastole. It will be end systolic volume. This is about 40% of the end diastolic volume. Let's talk a little bit about that. So we have at the beginning of your cardiac cycle, which starts with atrial systole, we have about end diastolic volume, which is about 130 milliliters of blood, give or take. All right. That is the end diastolic volume within that ventricle at the end of ventricular diastole. I'll put here ventricular diastole. Now, as we start to start our ventricular systole, start contraction, only a portion of this volume will be ejected. The volume that is actually ejected is what we call a stroke volume. And that is how much blood actually went into the pulmonary circuit and systemic circuit. Oftentimes is about 50 to 60% of that end diastolic volume. All right. So how do we calculate this end systolic volume? So if we have end diastolic volume minus stroke volume, it will give you end systolic volume. So if this is 100% and this is 60%, we will have left over 40%. All right. These volumes, such as end diastolic volume, stroke volume, are key, and they oftentimes related to volumes are similar for right ventricular systole and left ventricular systole. The differences are in pressure. The pressures within the right ventricle are much lower than of the left ventricle. Remember that the left ventricle is really thick, really muscular, so that allows the left ventricle to reach a higher pressure. And we need to reach a higher pressure because we are trying to overcome the pressure within the systemic circuit to open up that aortic valve. Now, the volume that we're ejecting from that left ventricle is the same as in the right ventricle, which at the end of end diastolic volume will be 130 mLs for both ventricles. All right. But the right ventricle doesn't have to have that big of a muscular pump because it is only trying to send blood to the lungs. Now, the amount of blood it will still be at the end of end diastolic volume for the right ventricle, about 130 mLs. However, it doesn't have to push so hard, so the pressures within the right ventricle are much lower than in the left ventricle because there is not such a resistance within the pulmonary circuit. All right. So, leaving that aside, we start ventricular diastole with the relaxation of the valves. All the valves are closed within this phase. Remember that the ventricular diastole is divided into the early phase and the late phase. Here we have isovolumetric relaxation, where our ventricles start to expand without an actual increase in blood flow. And this, during this time, allows for the atria to be, for the filling of the atria. Now, as soon as we finish a isovolumetric relaxation and the pressure within those ventricles has fallen enough and leading to the opening of the atrioventricular valves, then we will go to the late ventricular diastole. Now the AV valves are open, and now the ventricles will start to fill passively. So that brings us to the heart sounds. The atrioventricular valves close during ventricular systole. And when they close, they lead to this LUP sound, the first heart sound. The second heart sound is related to the closing of the semilunar valves. And the semilunar valves close during ventricular diastole. Remember that as we finish ventricular systole, at the end of that, the valves will close because the pressure within those ventricles will start to fall. And that is at the beginning of ventricular diastole. There are other heart sounds such as S3 and S4. These are oftentimes associated with two heart filling defects. Sometimes they may be benign, sometimes they may be pathological. Just know that the fact that they are there doesn't mean that they are expected. We normally focus on S1 and S2, which is the opening of the closing of the ventricular valves and the closing of the semilunar valves. Heart murmurs are related to abnormal heart sounds produced by regurgitation of blood through valves. Regurgitation means the blood flow from ventricles to atria. Remember that we always have blood flowing from atria to ventricles, not from ventricles to atria. And that is because we have atrioventricular valves. The valves prevent that backflow. If those valves are not functioning well, you will have the blood flow as soon as we start that contraction within the ventricles to flow into the atria. This will make it less efficient and it may sound like a heart murmur. There are different types of heart murmurs. So let's put everything that we've learned into perspective. So we talked about the cardiac cycle, which is the beginning of a period in which one heartbeat starts and one heartbeat ends. And we start all of it with atrial systole. So we're going to match everything right here to this green line, the beginning to the end of this green line. And you can see that we have a different graphs here. We have sound, we have cardiomyocyte depolarization with action potential, we have changes in volume, all right? We have changes in pressure into the ventricles and the atria. Let's go through each one of them. So we start our cycle with our P wave, and this allows for the depolarization of the atria. As we depolarize the atria, we will start contracting that atria. And the contraction of that atria, you see that the left atrial pressure increases. And because we're increasing the pressure, we're squeezing blood now into the ventricles. At the end of atrial systole, then we're going to start ventricular systole. So the ventricular systole starts with that first hard sound because we're closing the AV valves, and we have a QRX complex because we're depolarizing those ventricles. Here, remember that we're trying to now squeeze the end diastolic volume that we ended up at the end of atrial systole. That is our end diastolic volume. And our pressure within those ventricles will increase. All right, this is the pressure within the ventricles. The valves will close, the AV valves will close, and that is what gives us that first hard sound. As we go to that ventricular systole, we have two phases, the early phase and the late phase. The early phase, we have the isovolumetric contraction without actual blood flow changing. And during the late phase, we actually then open up those semilunar valves, and the semilunar valves then will allow the blood flow to move into pulmonic and systemic circulation. We can see here that there is a change in color from light yellow into dark yellow, and this is that early phase of that systolic ventricular systole. And the aortic valves open. Once they open, then we go into that late phase of ventricular systole. Once we finish ventricular systole, we go into ventricular diastole, which is relaxation. During this time, you can see that the pressure in the ventricle has fallen. Okay, the pressure starts to fall, and when that is happening, we have the end systolic volume is the end amount of volume that is left at the end of that closure of those semilunar valves. Remember that the AV valves are not closed, but once we close those semilunar valves, we're gonna have S2. Okay, so lob, dub. So the first hard sound is related to the closure of the AV valves, and the second hard sound is related to the closure of the semilunar valves. Once those semilunar valves are closed, we're going to end up with our end systolic volume. We'll continue through our late phase now. We have the early phase of that ventricular diastole, and we have the late phase of our ventricular diastole. The late phase of the ventricular diastole is known for the opening of the AV valves. You can see here that the opening of the AV valves close and the ventricle starts to fill. And as it starts to fill passively, then it will match up with the beginning of atrial systole. Here you can see some of the different changes within the heart as we go forward. So some key distinctions to know here. So there is something that is called heart failure, which means that your heart is not pumping well. Remember that the volume within both ventricles is the same at the end of end diastolic volume. The end diastolic volume should be about the same. Now, when we contract them and we eject, only a portion of that end diastolic volume is about 50 to 60% in each one. Now the pressures within this one and this one here are much higher than they are in the pulmonic, lower pressures. And that is, we're going to put in here left, I'm going to put it here right. That is because there is less resistance on the tissues in the pulmonic circuit than there is resistance in the systemic circuit. So we want to make sure that this is the same volume, because if we start to have a over amount of a blood collection onto one system than the other, then will lead to other issues, such as the one on the left. Let's say, for instance, we were to the right ventricular output exceeds the left ventricular output. If the right ventricular output starts to get higher and higher, then we're gonna overwhelm that left atria. So that left atria is not gonna be able to handle it. So there will be backup of blood into the lungs. The lungs won't be able to dump it. So if we start putting more blood out of that right ventricle, we're gonna lead to pulmonary edema, because the blood flow is not moving at the speed it has to, so we're not removing blood flow at the speed that we have to, so we have accumulation of fluid within the lungs themselves. You can talk about pulmonary edema, or you can recognize pulmonary edema because patients are short of breath. Now, in contrast, if we were to increase the cardiac output from the left side, all right, the pressure will build up, and that right atrium, if we start to increase more and more output from that left ventricle, that right atrium won't be able to handle it. So it will back up, but it will back up not only more into the lungs, but into the systemic circulation. And in that systemic circulation, it will lead to systemic edema. And that will lead to a form of a heart failure. This is just for your information to, for you to put it into perspective. How is it that these volumes affect the human body? And I just wanted to recap about action potentials within the cardiomyocytes and how it is shown on your EKG. Remember that the P is related to the depolarization of the atria, which means that as we depolarize, we're contracting the atria. Once we finish that depolarization, we're going to start the relaxation of atrial systole. Now, once we start atrial diastole, we're going to go into ventricular depolarization, and this is where we see the QRX complex. It is at the end of the QRX complex that we will have your entire ventricles contracted. We will start to relax your ventricles at the end with the T wave. And once it is finished, we're going to have complete relaxation of those ventricles.